Hey guys, welcome to my YouTube channel. If you like my videos, please subscribe and hit the bell icon. You can also search me on Facebook, Twitter, and Instagram. I'll see you around. You're watching Voice of South Asia. मैं हूँ आपकी host Nasheen Mulbrad. Welcome to Health Talk. There comes a time in everybody's life when you cannot decide whether to go to the emergency room or just call your primary healthcare doctor. US में इमरजेंसी रूम की जो कॉस्ट है या अखराजात हैं वो बहुत ज़्यादा हाई हैं. इस वजह से अक्सर लोग इमरजेंसी रूम जाते हुए डरते हैं. आज के एपिसोड में हम यही जानने की कोशिश करेंगे कि वो कौन सी सिचुएशंस हैं जिनमें वाकई आपको ER की तरफ जाना चाहिए और वो कौन सी सिचुएशंस हैं जिनमें जो कि इतनी इमरजेंसी नहीं है और आप अपने प्राइमरी हेल्थ केयर डॉक्टर को फ़ोन करके अपॉइंटमेंट ले सकते हैं. आज हमारे साथ एक बार फिर डॉक्टर A.D. ठक्कर मौजूद हैं. हेलो डॉक्टर, हाउ आर यू?
Good, how are you?
Good, welcome back to the show.
Thank you so much.
तो जनाब डॉक्टर A.D. ठक्कर का हम आपको इंट्रोडक्शन एक बार फिर देते चलें. डॉक्टर साहब is board certified in emergency medicine. He is also the attending physician of aesthetics at Youthology Med Spa. He has 20 plus years of experience in the field of medicine. डॉक्टर साहब, आज हम बात कर रहे हैं ER की. I know I've been there where I can't decide whether to go to the ER or just go to the urgent care or maybe just call my doctor. So I want to know, what is the difference between an urgent care and a full-fledged ER?
So first and foremost, it depends on how badly you feel. That is the absolute most important thing, because if you're feeling very dangerously sick, then the emergency room is the right place for you. And then if you have a regular problem where you can't get into your primary care doctor, then an urgent care is appropriate for you, and urgent cares are open a lot later as well, most of the time, than your primary care doctor.
Right.
And they may have additional services where your primary care doctor may not do minor surgical procedures, like if you have a boil that needs lancing, or they may not have x-ray services. So that's the difference, where you have to go to an urgent care center or even potentially an emergency room if it's late night and you're feeling extremely ill from it.
Got it. So I want to ask you next is, अक्सर लोगों को ये लगता है कि आप इमरजेंसी रूम जाएंगे and you'll be served. So are they actually first come first serve, or they're not?
It's not technically first come first serve. It's first ill. Most ill is first served.
Oh, okay.
Yeah. So that's why people get angry a lot of times.
Yeah.
They're like, "Oh, I came before that guy," but he may be having a heart attack and you just have a broken toe. So it's not like that we take you in time order.
Right. So okay. So that's a good clarity, that when you go into the ER, don't expect to be served first. It depends on the severity of your issue.
Yeah.
Got it. Okay. अगली बात हम करेंगे heart attacks पे, which is a very commonly treated illness at the ER. डॉक्टर साहब से हम ये पूछना चाहेंगे कि आप कितना frequently heart patients को देखते हैं, and I also want to know, what are the symptoms? How do you find out this is the time to go to the ER, that I'm having a heart attack?
Okay. Well, so heart attack is common in an emergency room, obviously, but more often it's chest pain. So it's symptoms, right? So the person may not know they're having a heart attack. What they know is that they're feeling pain in their chest. And the first thing that people worry about is their heart. Now, if it's their heart or not, a lot of times you don't know right from the beginning, because at the end of it, there's so many different organ systems in your chest. It's not just your heart. Your lungs are there, your esophagus is there, so basically your gastrointestinal system, right? Your ribs and bones are there, your major blood vessels are there. So it can be a lot of different things. Again, it comes back to how badly you are feeling. And the strange thing is that sometimes you're not necessarily feeling that bad. For example, diabetics, they have nerve damage a lot of times, so they may not have the normal symptoms of a heart attack that somebody else does. So you have to listen to your body and how badly you feel, but also you have to know your own risk factors. So if you have high blood pressure, diabetes, high cholesterol, strong family history, you're a smoker, or if you're using drugs like cocaine, all of these things,
they all contribute.
They contribute and increase your risk factors for a heart attack, because there are people, for example, that just will have tooth pain or jaw pain and it's a heart attack.
Oh wow, so there's not one symptom that you can pinpoint that, okay, it's a chest pain, I have to go to the ER.
If that was the case, my job would be easy, but it's not.
Right,
yeah,
it's not.
It varies quite a bit.
Right.
I mean, I can tell you the classics textbook definition is, left-sided chest pain, radiating to the left arm, associated.
Right, that's what I've heard. Usually your arm starts hurting, so it's the left arm.
Left arm commonly, but I mean, I've been doing this 25 years. Sometimes it's right arm. You know, not everybody follows the textbook. But if I was to give you a textbook definition, left-sided chest pain going to left arm, associated with nausea, vomiting, dizziness, jaw pain, fainting episode with it, or palpitations, you know, there's a variation of those things.
Right.
It can radiate to the back. So it just depends, but that's kind of classic. You know, we typically ask those of the patient. A lot of times they'll just be sweating for no reason, and it's not just a light sweat, but they may not have pain, but they know they feel bad, and their face and head are just pouring sweat, for example.
Right.
So if something looks abnormal, get it checked, especially if you have risks involved. And sometimes, you know, person has been completely healthy. I've had a 33-year-old man who was completely muscular.
And that's pretty young. You would never think somebody 33 years of age would have a heart attack.
I've had a 19-year-old with a heart attack.
Wow.
So, you know, when I first started medicine, you know, we didn't really think of heart disease so much in younger than 40. It would be a very rare thing.
Right.
But I've seen younger and younger ages, so you do have to take your chest pain symptoms seriously. Yeah.
Right. So in terms of taking someone to the ER, sometimes if somebody doesn't want to call 911 and they want to take their family to the ER, is there an advice or something that they should know while taking the patient to the ER?
Again, a lot of times it's how bad the person is feeling, and you know, if I were to say use common sense as far as how much risk do you see in this. Now, a lot of times people are not doctors, right? So they don't know these off the top of their head. But if you have an elderly person that's having signs of chest pain, you know, do you want to take that chance that in case it is a heart attack, that on the way there that they're having a bad outcome in the car? You know, what are you going to do if, God forbid, they were to collapse in the car and you can't do? So you have to kind of, now if you're, you know, again, I said I've seen heart attacks as young as even 19 that I've seen, but usually they also have something that's undiagnosed or they've used cocaine or something. So you have to kind of know your risk factors. So if you've had diabetes, high blood pressure, high cholesterol, you're overweight, you know, the more risks you have, the more chances that you should call 911 if you're having significant chest pain. Now, if you just have a light tinge and it's like, I just want to get it checked out, yeah, you know, you may drive there. But if you're feeling significantly bad, a lot of times most people can tell with their own body that something is majorly wrong.
Right.
Then don't hesitate to call 911.
So would you say use your instincts?
Yes, you need to. I mean, that's why we have the prudent layperson rule where, you know, it's not just what is technically an emergency, but what does that patient consider as an emergency?
Right.
And that's where you have to listen to your own body. And, you know, sometimes you're going to get it wrong and you're going to have a big expensive ER bill, or you're going to have an expensive ambulance ride. But the contrary is that if something adverse were to happen on the drive there, and you know, the worst thing,
take that risk.
Yeah, and the worst thing is if you're driving yourself, like what if you collapse, you're having chest pain, you're not listening to your body saying, hey, I need something done, something's wrong, and then you get into an accident because you
worst nightmare of anybody.
Yeah,
right.
And, you know, collapsed. So
right. Well, next thing we will talk about fever. Fever is very common, you know. बच्चों में fever होता है तो माँ को समझ नहीं आता कि कब ER ले जाना चाहिए, और बड़ों में fever होता है तो हमें तब भी समझ नहीं आता कि what is the maximum level that you reach and you should go to the ER or you should just call your primary care doctor. So you tell us.
So again, fever is one symptom, and it comes back to how bad you are feeling, okay? And the reason I say that is because there's other medical things that I'm looking at as how bad somebody's feeling. But, you know, if you're getting to the point of fainting, for example, or you're feeling so sick, and the reason that happens is that if you're getting septic, you know, fever, if it's, you know, as a sign of infection, if you're becoming septic and, you know, bacteria is getting into your bloodstream, your blood pressure may be dropping and you're getting lightheaded, dizzy, or feeling faint, that's one level of fever. But there's no specific number that, okay, this constitutes a temperature emergency. Temperature is one sign of infection. Now, the thing is, you would think that the higher the fever in kids, for example, the more dangerous. But the reality is that if, you know, for example, and again, it's not all cases, again, it's very variable, but a lot of children sometimes may have 105, 106 fever, but they may not be as dangerously ill as if, let's say, an adult has 100. Like an adult, if an adult has 105, 106, they're having something majorly wrong in infection, right? But kids, a lot of times, even with minor viruses, can have that high of a fever. And the converse is true. Some children, even as a fever of 101.5 or 101.2, can have life-threatening ill infection. So the key thing that I want to tell people is that don't torture the child or yourself or your family member by not treating the fever. A lot of parents, for example, will come in and say, well, I didn't treat my child's fever because I wanted you to know that I wasn't just lying or like,
right, and that's actually my next question right here. कि कभी-कभी मुझे भी ऐसा situation हो चुकी है पहले कि ER जाने से पहले I was thinking, should I go ahead and take the OTC fever reducer, or should I just let the doctor see how high my fever was?
Yeah.
So do you actually suggest go ahead and take your OTC fever reducer before you come in?
Yeah, take it. I mean, it's ideal if you have a thermometer to measure it, because we would like to know that, okay, did you hit 105 or did you 100.5? You know, so height of the fever can mean something. It's not that it doesn't mean anything to us, but also the thing is, and so for example, more children with fever come to the ER than more with adults. Now, elderly patients, of course, they come with the fever, but like the average, like 20 to 40, 50-year-old, they come with fever sometimes, but it's the extremes of age that people really worry, like, okay, does this fever mean something serious?
Right. So we're in conversation with Dr. A.D. Thakar. इनसे हम बात करेंगे emergency room के बारे में इस break के बाद. Stay tuned. Welcome back to Health Talk with Nashin Mulbrad. बात कर रहे हैं हम डॉक्टर A.D. ठक्कर से ER के बारे में. हमारा नेक्स्ट सवाल आपसे ये है कि what is the difference between like, I wouldn't really say difference, but how do you find out if you have broken a bone or it's just a sprain?
So that's a tough one even as a doctor, because sometimes we won't know that something's broken until we do the x-ray.
Okay.
Now, there were all kinds of rules when we were first in residency about these 6 different criteria of whether something to determine whether to do an x-ray of an ankle, for example. Like they had different rules. Honestly, in private or in regular practice, if you're coming in with swelling, tenderness, I'm gonna wind up x-raying you, because there's many times that you don't need bone popping through the skin to know it's broken. There could be hairline fractures to that. So a lot of times, if it's hurting enough where you can't walk on it, or if it's so swollen that it's hard to move a joint or a wrist, like for example in a wrist, just go get it x-rayed. Right.
So it's better to just go to the ER instead of just waiting it out.
So it depends. You can wait it out if it's not affecting your day-to-day life. If you wait a day or 2 or 3, it's not going to harm you unless, for example, you can't walk and you can't get around. Then you need X-ray that day. Or if you literally can't move your arm, then that it's a little bit more tolerable. As in you're not relying on to get around. So, but it's not going to harm you in the sense that as long as it's not a major break where there's a blood flow issue. So that's the main thing. Like if you break something really bad, chances are you're going to come in anyway. But if it's pushing on your blood vessels and nerves, if your hand is turning blue, for example, or it's numb and tingly and you can't feel it, yes, you need to go urgently. But if it's trying to decide whether it's a sprain or break because it's just swollen and a little bit painful, well, you can wait a day or 2.
Right. So ये बताइएगा कि when it comes to sprains, can you just treat it at home? Are there any ways?
You can. I mean, so there's a common word that we use even with fractures or sprains. The word is RICE, R-I-C-E. So R stands for rest, I stands for ice, C stands for compression. So compression means like an ACE bandage, for example, or if it's a small fracture, we use a splint, which is cast-like material, and E stands for elevation. So rest, ice, compression, elevation. If you think of that in terms of any orthopedic injuries, that's the very common treatment of both types of injuries.
Right. So that's really good information and actually very easy to remember too.
Yes.
Awesome. Next, we will talk about car accidents. Unfortunately, car accidents are very common. As an ER doctor, what are some of the advices you would give to drivers who get in car accidents that you wish the driver had taken care of, or somebody who's bringing them into the ER had taken care of?
Yes. So, a lot of times the problem is, for example, in a major car accident, that somebody has refused ambulance driving them to the emergency room, and you have to kind of consider how bad the accident was in that case, because if you were going 70 miles an hour and you were hit and you're having some neck or back pain, you could have a fracture there that can paralyze you eventually, so you have to kind of take that seriously. Like, if you were in a bad car wreck, then don't refuse ambulance traffic. But if you had a little bumper, like a little hit, and you're not having all that much pain, then you don't necessarily need to go to the emergency room right then and there. If you're having some mild aches and pains, initially icing the area, taking some ibuprofen. You can't take Tylenol, of course, if you can't take anti-inflammatories, because let's say you have a stomach ulcer, or it upsets your stomach, anything like that, or if you're on blood thinners. But typically, the same thing, resting it, icing it, taking Tylenol or ibuprofen, and seeing what happens. Not every car accident has to come to an emergency room.
Right. So whenever we hear about car accidents, we also hear about concussions. What's a concussion, and what do you do as an ER doctor when a patient comes in with a concussion?
So concussion involves head injury, right?
Okay.
And so the difference between a concussion and actually, let's say, a skull fracture or hemorrhage, the symptoms can be the same. The difference is that when we CAT scan the person, they don't have a skull fracture or hemorrhage, but they're having the symptoms of an internal head injury. So typically we ask patients some very common questions if they've had, they, let's say, for example, hit their head on a windshield in a car accident. We say, did you lose consciousness? Now, losing consciousness is only one symptom, but let's say is it a severe headache? Do you have nausea, vomiting, dizziness, blurred vision? Did you faint? So those are common symptoms. Now, on the practical side, even more than loss of consciousness, one of the big things, especially, let's say, for example, children, if your children were sitting in the back and the car seat failed and they fell forward and hit their head on the window or the windshield, for example, one of the big common things that I've seen in children when they come in, and if I'm really worried about a brain hemorrhage, is vomiting. You cannot tolerate blood around your brain. Okay, and that's not a concussion, that's an actual skull fracture with hemorrhage, because that's what we really care about right away in the emergency room is, does this person have a skull fracture and hemorrhage? The concussion is then after the fact. Like, so if you have enough symptoms, I'm going to CAT scan you, and if I don't find swelling, hemorrhage, or a fracture, then if you're still having, let's say, headache or a little bit of nausea, dizziness, or blurry vision, that's a concussion, which means that the inside of your brain was moving against your skull. So you're going from a very fast speed, let's say, all of a sudden it's dead stop, and when that happens, there's space inside your skull, so your brain basically got bruised. It didn't get hemorrhaging, but it did get bruised inside the side of your skull. And so then you're going to have, let's say, and it can last for weeks at a time, like 2, 3, or more weeks.
But it can self-heal?
Concussions self-heal. It's multiple concussions, so concussions happen in other cases too, right? Sports injuries.
Like boxing.
Boxing and football. So these are common things that when people get repeated, multiple concussions, then you have long-term damage that happens, because you may not see the damage on plain CAT scan, because again, that's looking for big things, like is there a swelling, hemorrhage, or skull fracture, but there's damage at the nerve level that's happening, that's adding up over time, and that's when later on you find that these people have, let's say, movement disorders, like they're getting Parkinson's disease, and they're having difficulty walking, and they have motion, like they're tremoring, or they have dementia early, like Alzheimer's being one type of dementia where you're losing your memory and such. That's the danger with multiple concussions.
Next thing we're going to talk about is cuts and burns. I'm sure you do see a lot of people coming in with cuts and burns. But one thing I want to know on behalf of our viewers is sometimes you can't really tell if the cut is big enough or the burn is big enough to go to the ER, or is it just going to self-heal, or we can self-medicate at home?
Sure. So with cuts, one of the big things is, a lot of times when it needs stitches, it's because the edges are not together, they're apart. And when they're far apart, then all this tissue in between is going to be scarred, right? Because those edges are not going to magically come close together.
Right.
So that's a kind of a quick idea, is that if it's the big cuts are far apart and we need those stitches to bring them close back together, you know that you have to go get stitches, and whether that's an urgent care, ER, usually most primary care doctors don't do that in their office. It's usually urgent care or ER. So talking about cuts now, the key thing with cuts is what's really important, and a lot of people make this mistake, is they first are obviously wanting to stop the bleeding. That's the first thing everybody tries to do, and then they're like, do I have to go? Do I not have to go? Problem is that the next day either it continues bleeding or they've reassessed the situation and it still looks far apart, and they're like, maybe I should have gotten stitches.
Right.
Problem is that after 6 hours, we don't like to close those wounds because, and we'll give a little bit more time, like 12 hours to 24 hours for faces, because the blood supply to the face is really good, so the infection risk is a lot less. But we don't like to stitch after 6 hours because by that time so much bacteria has entered the wound already. Even if you cleanse it, bacteria can still get in there because it's so wide apart, that if we close it up, the risk of infection is a lot higher.
Okay, so when you get a cut, you should really go to the ER within the first 6 hours of getting a cut.
Especially if it looks like to you that it might need stitches, then go get that looked at and assessed to see if you need stitches.
Right. What about burns?
So burns there's twofold, right? It's like how extensive all over your body versus a very small area, but also the depth of burn. So there's, first degree, second degree, third degree burns.
Yeah, I always heard that, but I never know, how do you assess?
Right. So that's the depth into tissue, not the length of the tissue. So first degree is usually like a sunburn. It's just the top layers of the skin, and it creates a redness, painful redness.
Right.
The second degree, it's automatically, when you start seeing blistering, that's automatically second degree, because it's heated up enough of your deeper tissues that now there's inflammation fluid developing, which is why you get that big blister on top.
Okay.
So that's second degree. When you get actually into third degree, it's so deep that actually it turns out not to be painful, because you've actually burned through the nerve endings, and it's usually the tissue's very white. Like it's burned all the way down and through, and of course those are the most dangerous burns.
Is that where it touches your flesh? Or it's above that?
Well, I mean, depending on what you mean by flesh, it's all of your skin and everything's considered flesh. But if you're talking about it's gone down to the level of, like, let's say muscle, bone, it's third degree, and that's a much deeper burn.
Got it.
Yeah.
So I know from my past experience, when I have had a couple of people that I know, my family members and stuff, when they got burned, and we just didn't know what to do in that situation. क्या पानी लगाएं, पानी ना लगाएं, कपड़े से साफ करें, टिश्यू से साफ करें, या क्या करें? So I really want to know, what, as an ER doctor, what would you suggest if somebody gets a cut or burn, how to really treat it at home before heading to the ER?
You do want to cool off the tissue, because the longer the heat stays within the tissue, the more internal damage it can cause. Especially, let's say, for example, it's immersed in oil. Water will quickly drip off like a hot water burn.
And this is a very common thing, especially when you're cooking, you do get burned with, oil.
Yes. So you want to cool it off. So, applying water or ice bath is the right thing for two reasons. One, to cool off the tissue, but also it helps with the pain. Because even if you take Tylenol or ibuprofen at that point, it's going to take 45 minutes or more to kick in your system. So for immediate pain relief.
Right.
Now we're not talking about ER treatments here, not just home remedies, for example. I mean, yogurt is a good, yogurt, sour cream, anything, because again, it's a thick,
it's like
cold,
ointment.
It's a thick, cold ointment that's basically absorbing the heat out of the tissue. It stays on there. So if you dunk your hand into
cold
yogurt, it's a good way to cool off the tissue quickly.
Interesting.
Yeah. So but in the ER it's different. We have burn ointment, like Silvadene ointment. Silvadene is it's a silver-based ointment. We don't use it on the face because it can stain your face silver.
Okay.
But everywhere else on the body, that's the burn ointment that we prescribe most of the time. And then if it's on the face, we just do Neosporin, because again, it's the antiseptic, like reducing risk of infection is the main thing.
Right.
But there are times, for example, that we have to worry about sending a patient to a burn trauma center for admission, because the burns are extensive. So even if you have, second degree burns, it doesn't have to be all the way third degree. You have second degree burns, but if enough of your body is burned, you're going to get dehydrated, because there's going to be a real increased fluid demand on your body, and a lot of fluid is going to be seeping out of those tissues that are burned.
Right.
So that's when it becomes a much bigger deal. But usually by that time, people are coming in because there's so much of their body is burned that they're going to seek treatment very commonly.
Right. Well, we're in conversation with Dr. A.D. Thakar, and we're trying to find out in what situations you should go to the ER or just call your primary care physician. We're going to take a small break. Stay tuned. वेलकम बैक टू हेल्थ टॉक। मेरे साथ आज मौजूद हैं डॉक्टर A.D. ठक्कर जो कि ER डॉक्टर हैं। इनसे हम बात कर रहे थे डिफरेंट ER सिचुएशंस पे। डॉक्टर साहब, अगला जो सवाल मैं आपसे पूछना चाहती हूँ, हाउ सीरियस आर फूड एंड सीजनल एलर्जीज एंड व्हेन टू हेड टू द ER व्हेन यू हैव देम?
Well, with any allergies, the key thing is there's, of course, the minor end of the spectrum all the way to life-threatening reactions, right? So, again, on the minor spectrum, you're talking about maybe a rash. Do you necessarily have to go to the ER? Well, if it's all over your whole body and you can't stop scratching yourself, yes, even a rash can lead to an emergency visit. But typically at home, you can try Benadryl first. The things that we can add on in the emergency room is steroids. We can add on epinephrine if you're getting even much more sicker, and so that goes into like the next stage. More than rash is if you're starting to feel, let's say, some swelling. If you have a little lip swelling, a little bit of tongue swelling, but it's not affecting your voice box yet or breathing tube yet, then again, it may be just Benadryl and steroid. But if you're starting to get, let's say, feeling like your throat is closing, or that can affect your breathing, or also, let's say, you're wheezing, we may have to give you epinephrine to open you up. We may have to do a breathing treatment, like the way asthma is treated, the same way. So those are things. Definitely, if you have enough swelling where your throat is closing, or you're having difficulty breathing, or you're getting lightheaded, dizzy, because that means you're having anaphylactic shock, which is the type of allergic reaction that you can die from. You're going to get lightheaded and dizzy because your blood pressure goes low. You can faint. So those are symptoms you definitely should get to the emergency room.
Got it. Well, we're in the midst of coronavirus pandemic, and we are kind of trying to learn how to live around it and how to go on with our lives right now. I do want to ask Doctor about the respiratory infections, and I'm assuming coronavirus is considered a respiratory infection. So how do you treat those patients in the ER?
So if you're talking about in general, respiratory versus COVID right now, might be slightly different in that, we are still creating protocols of what's going to work or not work with COVID. But in general, common colds and all are going to be same. Staying hydrated with fluids, using Tylenol or ibuprofen for having reduced fever, and then depends on the respiratory infection. There's ones that we need antibiotics for, other ones we don't need antibiotics for. With COVID, of course, the main reaction is the lung reaction, where they get fluid and inflammation in their lung tissue, which makes this a serious disease. But still, in my experience so far in the ER, yes, those patients are there, but we are also seeing a lot of asymptomatic patients. They're just coming in because they were exposed to somebody, they're COVID positive, but they have either no illness or they have very minor illness. So again, when it's minor, it's just like anything else. It's just symptomatic treatment, or if there's no symptoms, really it's just quarantining themselves from exposing others that may get sick from them.
So when they're quarantining themselves, what are some of the things that you guys suggest that they should do at home, like in terms of staying hydrated or taking some kind of medicines or any over-the-counter medicines?
If they're not feeling sick at all, it's just they're quarantining us to save other people from getting exposed.
Right.
Usually it's about a 14-day quarantine from the time of being positive. But if they're having, let's say, a little bit of sore throat, when we worry about COVID more is when they're actually having high fever with a cough that's causing shortness of breath, and when we check they have a low oxygen level, those patients we're hospitalizing. But if you're just, let's say, having a little bit of sore throat or cough, yes, you can still use over-the-counter cough medicine or Tylenol or ibuprofen for fever. It's more that if you have significant symptoms, then there are protocols involving Zithromax, for example. There was hydrochloroquine that was used. There's now initially steroids were not recommended for inflammation for it. Now, steroids are being recommended. But these protocols are constantly changing for COVID because as studies come out, so there's no set stone yet protocol for this, until the vaccine comes out.
Right. Well, doctor, the last question I want to ask in today's episode is, what do you suggest as an ER doctor and a doctor in general? How do we actually how do we live with this virus around? Because it seems like it's not really going anywhere anytime soon. So what's your advice to us?
In my personal opinion, it's really, you can't predict who's going to get sick with it. Yes, people that have increased risks, like the elderly population or people that have multiple medical problems, they're just like any other disease, they're more prone to it like anybody else. But this is like trying to determine, who's going to have that immune response that ultimately causes that fluid in the lungs and inflammation. And the way I equate it with a lot of things is that if you were to take, everything is about balance in life, right? And so if you were to have a country that has a extreme army and air force and the military, right, is the right way. If you have a huge army ready to fight, the problem is that if you don't have that in balance, at the end of the day, is the enemy going to kill you or is your own army going to suppress you, right? It's the same way in COVID. Is your own immune system is attacking your lungs, and to try to predict if there's 10 people in a room who's going to have that exaggerated immune response, you can't. So at some point, we're going to have to realize that, of course we want to vaccinate people to improve the odds for everybody, but at the end of it, we're going to have to at some point slowly integrate back into normal life.
Right. Well, thank you so much, डॉक्टर। आज के एपिसोड में काफ़ी अच्छी हमको इन्फॉर्मेशन मिली और हम उम्मीद करते हैं कि हमारे व्यूवर्स को भी अब जो है वो ज़्यादा बेहतर डिसीजन लेने में हेल्प मिलेगी, वेदर टू गो टू द ER इन दैट पर्टिकुलर सिचुएशन और नॉट। जनाब, यहाँ होता है हमारे एपिसोड का इख्तिताम, और अगर आप अपने कमेंट्स और सजेशंस हमें भेजना चाहते हैं तो हमारा ईमेल एड्रेस है info@vosa.tv। अपना और अपनी फैमिली का बहुत ज़्यादा ख्याल रखिएगा। हम आपसे मिलेंगे अगले एपिसोड में एक नए टॉपिक के साथ। अल्लाह हाफिज़।